hematomas, and I think this is a quite interesting topic, and that explains many of the findings we have when we deal with subdural patients. I have no disclosures, and I'll start with a case that I have from this year, and then later I will review the literature. So this is a case about 85-year-old male, right hand dominant, bilingual. He's French and he lives here in New York. He was skiing in the France, and then he fell with head strike, no loss of consciousness, not as severe as the picture shows, of course, but he did very well. It was a minor fall. He kept going. And later he came back to New York, and then he was noticing a progressive but mild unsteady gait, which then his primary care physician ordered an MRI and that was about 3 months since the fall. And the MRI revealed that large left chronic subdural hematoma with mass effect, midline shift, and we can also appreciate edema and membranes inside the subdural. He then went to ER. The CAT scan confirmed the subdural hematoma, and we took him for boreholes evacuation. In general, I try to treat those kids with boreholes. However, we knew that we would encounter membranes, and then eventually he could need a craniotomy. So this is the picture after we converted the boreholes into craniotomy. We see here the outer membrane of this chronic subdural. When that membrane was inside, we saw a very thick clot. So it was not so liquefied, therefore it didn't come out with boreholes only. But it came out very well. That's the inner membrane, which we cleaned a little bit more. But as you know, the inner membrane of the subdural hematoma, of the chronic subdural hematoma, is not so inflammatory active as the outer membrane, and that membrane should not be removed. And also that it's linked to high risk for seizures if you attempt to remove the inner membrane. So this patient did very well. The post-op scans just showed a residual subdural, which is very, very common in those cases. He did have improvement of his symptoms, and he was discharged home 3 days after surgery on Capra, and then he did very well until the next day when he came back to the ER with word-finding difficulties and slurred speech. And he was having those events. So that was 45 minutes the first time, and he was having on and off those events when he was fully awake without any motor or no tonic-clonic movements, just purely the aphasia. And he would recover, and then later on he would resume having those symptoms. Of course, we did a CAT scan to rule out an acute hemorrhage, which the CAT scan was stable. The CTA didn't show any LVO. The MRI showed post-op changes, but no strokes, no acute findings. And then, of course, we thought he might be seizing, right? So then we admitted him to the EMU. That he went to Mount Sinai West. And then we increased his Capra, and he was put on video EEG. Now, surprisingly, every time he would have those aphasia episodes, that would not have a correlation with EEG in terms of seizures. He was monitored throughout some days, and every time he would have an ictal event, there was no correlation with EEG. Eventually, the Capra was increased, and that helped to control some of his symptoms, but he was discharged with some degree of aphasia, which prompted to add VPAT a few weeks later. And actually, he will only improve completely about 1 month after surgery. So until then, he was presenting some on and off aphasia episodes. But he did very well after that. Now, it's important to discuss the occurrence of transient neurological symptoms in patients with chronic subdural hematomas. It's very common to see those events happening post-op. And as in this case, the first thing that comes to mind is the seizures, right? Because we know seizures has a high incidence in subdural hematomas, up to 25%. However, sometimes those ictal events are atypical in terms of semiology, evolution, and response to anti-seizure drugs. And then if it's not seizures, then what could that be, right? So there's this concept that is being published, and it's called NESIS. This Canadian group labeled non-epileptic, stereotypical, and intermittent symptoms as a new entity called NESIS that they try to apply to subdural patients. In the paper they're going to review now, they followed patients after subdural hematoma evacuation, acute and chronic, that presented transient neurological symptoms. And they noticed that those patients with transient neurological symptoms and negative epilepsy workup, they had a different evolution than a patient with seizures, meaning the patient with positive EEG. So they divided those patients in two groups. One, the case group that were patients with negative EEGs, and control group that were patients with positive EEGs, meaning they likely had seizures. And the demographics were pretty much the same, except that platelets was more frequent in patients with negative EEG, and GCS score was better also in patients with a negative EEG. And then the semiology was strikingly different. That's what is very important for us to review here. The control group, meaning the patient that have a EEG with seizures, they have more positive symptoms, and these were statistically different. Positive symptoms. They also have motor and sensory symptoms more often, clonic movements, impaired awareness, CAT scan deterioration throughout the monitoring, better response to a second AED, and unfavorable orientation of discharge, and also higher mortality as an outcome. Whereas a patient with a negative EEG, so case group, they didn't have all those symptoms. They actually have more aphasia speech symptoms, and the duration of the symptoms were longer, more than 5 minutes. But those patients, they have a better outcome than a patient with a positive EEG finding. So they tried to create a scoring system where they would attribute a weight in to those symptoms, and they create an eight-tier scoring system where if the score was more than 4, that would be suggestive of patient having nesis. And nesis would be this patient with a transient neurological symptoms without a positive EEG, without an EEG correlation. And the threshold of 4 points in that scale would have a 96% of specificity and 100% of sensitivity. So it was actually pretty good. This other paper also looked into chronic subdural patients with 84 patients. And what they saw was that from that 84 patients, 26% had transient neurological symptoms after surgery. And for those patients, almost 60% would fall in that nesis group. And they also confirmed that those patients, they have a better outcome in overall. The mortality was 0 versus 33%. And also those patients did not respond so well to anti-seizure drugs as patients with a positive EEG. So it's important to discern, to differentiate those two groups, because as you can see, not only the outcome is different, the treatment might be different to treat those patients. The literature of subdural hematoma and corticosparing depolarization, as you know, the theory behind this nesis is that the underlying process explaining those ictal events is the corticosparing depolarization. And the link between subdural hematomas and corticosparing depolarization is very limited. What we have in the literature so far, and there are some new papers we're going to review, but the old papers, what they just do is to correlate the occurrence of TIA-like symptoms in patients after subdural hematoma evacuation. But there's no causality, there's no explanation in terms of the pathophysiology of those patients. So these are two examples, patients from papers from 1983, and the other one from 1992. And they just confirmed that TIA-like events, mostly with aphasia, in patients that had a negative EEG. Now, this paper from 2020, study 40, it was a prospective study of 40 surgical patients after chronic subdural evacuation. Those patients that went to craniotomy, small craniotomy, and after the craniotomy, they placed a cortical strip for ECOG monitoring post-op. And they found in those 40 patients, 15% of them presented corticosparing depolarization. And what was also interesting was that those patients with corticosparing depolarization, half of them had post-op deterioration, more so than the patient without corticosparing depolarization. 50% versus 8.8%. And in terms of the onset of the neurologic deterioration, the two patients in this cohort that had early neurologic deterioration, both of those patients had sparing depolarizations. So this is just an example. So you see here the electrode, the cortical surface electrode adjacent to the subdural drain. And on the right side, you can see two images showing the propagation of very typical propagation of the slow propagation of the cortical spread depolarization wave, which you can see spanning from the electrodes 1 to 6. And which is remarkable is that in that picture, all that study time is 30 minutes. So it's a very slow propagating wave, which is astonishing in when you think about the brain, where everything is so quick, all the information, all the electricity is so quickly. And this is a very slow, about 2 to 6 millimeter propagating wave. I find this, so this is the same group. This is just an example of one of those 6 patients that had the cortical spread depolarization. This patient was doing very well, was under monitoring. And by the way, those patients were being monitored, but they were not, they were blinded. So they wouldn't know when the patient would have a cortical spread depolarization until the study was concluded. So this patient was being monitored. And later on, this reviewed retrospectively after, they removed, they noticed that the aphasia onset correlated with the occurrence of the cortical spread depolarization. And you can see here in blue, this when the patient started to, these are the events of the cortical spread depolarization correlated with the onset of aphasia. This patient was taken back to the OR because they thought that there would be a small stroke or small collection that required revision. And he did not improve after surgery. He only improved around 2 weeks after surgery. So I find this important because we may have patients with deficits after subdural hematoma evacuation when we are compelled to take back to the OR because we assume that there's something we're missing and a small collection that is causing the symptoms. But in this case, for example, it was a cortical spread depolarization causing the aphasia of this patient. Now, the reason behind why would cortical spread depolarization occur in subdural hematomas is because the subdural hematoma is a very pro-inflammatory pathology, right? We reviewed here already, I think last year we presented this. There's a lot of interactions of immunomediators with cytokines that it promotes a very inflammatory process that activates the microglia. Now, also those patients, they have increased intracranial pressure. And that what that does is, of course, that can impact with the CPP if the autoregulation is not well preserved, also affecting the microvascular resistance. For chronic spread depolarization, it's important to have a supply demand, an energy supply demand, in order for the area to repolarize after the depolarization. If that's not met, you may have a secondary neuronal injury, which can be very deleterious to the brain. This phenomenon of cortical spread depolarization was discovered in 1944 by Aristides Leão. He was a Brazilian physician. He was doing his PhD in Harvard, and he was actually not studying this. This was totally an incidental finding. He was looking to experimental epilepsy. He was working in rabbits, and he would do craniotomy and do small electric stimulation and would record supposedly the propagation wave of the epilepsy along those electrodes. But what he saw was actually quite the opposite. He saw, instead of seeing an excitatory wave, he saw a depression of the signals, a suppression along the electrodes. And that would be from the inside area where he triggered the wave, spreading along the electrodes all the way, if you can see in that picture on the left side, all the way back from the electrodes 1 to 7. And as you know, it occurs in the gray matter in patients with acute injuries. So we are talking about subarachnoid hemorrhages and also TBI, strokes as well. And then, so it's a depolarization wave that is followed by electrode silence. That silence lasts for about 5 to 20 minutes. That spreading depolarization wave, it propagates very slowly and about 2 to 6 millimeters per minute. And it causes a near complete depolarization of neurons and astrocytes. During that spread depolarization wave, there's a hyperemia. So there's more blood flow for that area, which is followed by oligemia in the phase where there is this transient electrocerebral inactivity that would then be reperfused when the repolarization phase comes in. Now, to meet the repolarization phase, there has to be a metabolic demand from the brain. So if that demand is impaired by the ischemia, if we're talking about, for example, penumbra area or an area that is around the cortical injury from a traumatic brain injury, that recovery from this depolarization may not be met. And that's when you may have expansion of penumbral and cerebral infarcts. So it's very linked. It's very often occurring in malignant strokes in up to 100%, subarachnoid hemorrhages, migraine, traumatic brain injuries is about 50 to 60%. Now, of course, these numbers are very, we don't monitor those events so often, right? So we don't really know how much they occur. All the cases that we have, at least for TBI, they have a small number of patients. So the incidence can be even higher. And the concern is that because this corticospinal depolarization, it may have a negative, and it may be a prognostic impact when that happens around the lesion, the traumatic brain injury. And it's linked for expansion of the penumbra, and that may impact potentially salvageable neurons. Now, one question is that, would this event be a marker of injury severity, or would that be an independent causal factor that would be affecting the outcome? This paper tried to answer that question, and by studying 109 patients after craniotomy with electrocorticography, they found an incidence of 56% of the corticospinal depolarization. And their conclusion was that when they compared with the prognostic score, this spinal depolarization were significant predictive of worse neurological outcome. So it seems to have a very robust correlation with a worse outcome. The problem with corticospinal depolarization is that in order to diagnose, you essentially have to do an invasive monitoring. With this paper tried to correlate scalp EEG findings with ECOG, and unfortunately, they didn't find so much of a correlation. So you do need a invasive monitoring to depict the corticospinal depolarizations. And ideally, according to this paper, with subdural strips more so than the depth electrodes. This other paper compared how to diagnose using depth electrodes and cortical strip. And actually, they found that you can use depth electrodes. So the cortical strip will be the gold standard, but also the depth electrode can also be an important tool to diagnose this, which is helpful because it's easier if we're talking about trying to monitor patients in ICU. It's easier doing a small borehole just to insert the depth electrodes than a small cranny to insert the subdural electrodes, right? So this paper showed that the depth electrodes were able to find the depolarization events, and also the subcortical electrodes were able to find the depression and the cortical silence following the depression. Now, so we know that this event happens in the brain. We know that it happens in TBI and in chronic subdural patients. And the question comes in how we can treat, if there's anything to be treated, what can we think about therapeutic for this event? It's important, first of all, to minimize risk factors for corticospinal depolarization. What is shown that hyperglycemia, hypoglycemia, hypoxia, and hypotension all can lower the threshold for corticospinal depolarizations. And in terms of actively treating those events, migraine prophylactic drugs have a very important role. So calcium channel blockers may be used. NMDA receptor antagonist, ketamine, is also a very discussed drug. Lamotrigine and VNS also have been shown some promising results. In terms of anti-seizure drugs, besides lamotrigine, topiramate also seems to be very effective for treating. Looking for ketamine, as you know, is an NMDA receptor antagonist. It works by binding and stabilizes the glutamate binding site, and it stabilizes the membrane of the neuron, and it prevents the mass depolarization of the spreading depolarization. This paper showed that the higher the dose of ketamine, the lower the number of spreading depolarizations. So this could be a potential agent to be used in patients to prevent and to treat actually the spreading depolarizations. Now, two questions that still remain open. Is corticospinal depolarization detection necessary to start treatment of TBI patients? So we know it's very challenging to diagnose. It requires invasive monitoring. Do we have to necessarily detect to start treating, or can we use a scoring system, as we discussed in the beginning, to infer the patients having spread depolarization then treated? Another question is, so should we, because we know it happens so often, should we then plan to do therapy to all patients that on the risk factors for the spread depolarizations, which of course is very controversial, right? You may have a lot of patients that don't need to be treated. The occurrence of cortical spread depolarization, at least in the chronic subdural patients, they are not necessarily a bad event. Many patients that were monitored, they had the spread depolarization without a clinical correlation. There's an overall trend of some papers showing a worse outcome, but not all patients will need treatment. So if you're talking about, for example, giving ketamine, which is a sedative, you would be having for sure a longer hospital stay. You have many patients undergoing treatment that wouldn't really need that. So it's a very debatable. It's still not certain when to treat all patients. So in summary, I think it's important to consider NICEs as an entity in subdural patients, because that can optimize your workup. You can plan a better anti-seizure medication for these patients. You may even avoid unnecessary reoperations if you're able to treat and improve those symptoms. You may reassure the patient that overall the prognosis is better. It's important to continue investigating better modalities, treatment modalities. That for now, what have been used is arginine, magnesium, as we mentioned, lamotrigine, topiramate, ketamine. But I feel that, of course, much more should be done. And I think we're still going to find a better treatment regimen for those patients. Okay, in summary, that's what I wanted to convey. And I would like to answer any questions you guys have.
Aldo, thank you. This is Ted. You can hear me okay?
Yes.
Awesome work. And I think that one of the possible ways to improve the extracranial yield on this would be to try to go for a high density EEG, just to see if there's still a way to capture that, because of course then the risk is significantly limited compared to invasive monitoring with subdural strips. Maybe that's a way to increase the density of signal and the temporal and spatial resolution to still be able to catch these depressions. And that's something that, you know, is set up fairly nicely at Mount Sinai West. Maybe we can extend that over to MSM and other trauma centers.
Yeah, great. We should explore that, Ted. Absolutely. Especially for this chronic subdural population, right? Because we're not talking about acute TBI, which is it's more compelling to, after craniotomy, we live in a gradient strip. But these are patients, normally they don't require neuromonitoring for a long time, right? So I think what it's saying could be a very interesting study.
Devaldo, in the case.
Is Ben on the call? Because he's got quite a lot of experience in signal density, subdural electrodes, and the like. I don't see him though. Oh, he's there, but he's not. He's an attendee.
Yep. Moving him up. While he's, there we go.
Ben, do you have any comments on this?
Thank you. Thank you. Yeah, no, I'm here. I think there's, as you know, I'm very biased here, but I think there's tremendous potential for new technology to provide us access to recording and diagnosing these these electrical events.
Okay, Chris, did you have comments? I'm sorry.
I was going to ask Devaldo, the papers you were showing about subdurals were mostly post-surgical. Is there something about the surgery that's precipitating this phenomenon in subdurals, or is it the blood itself?
Yeah, good question. It was not. They don't mention the surgical technique per se, or what they said was the electrodes were placed near the contused area if there was an acute subdural or acute TBI. For chronic subdurals, they just placed adjacent to the drain, but they didn't mention specific details about surgical technique.